All right, so I think we'll go right into our final talk of the day. We save one of the best for last here. So I'm going to go ahead and reintroduce someone we've met already, Dr. Sid Singh. So a reminder that he's an associate professor of medicine in the Division of Gastroenterology with an adjunct appointment in the Division of Biomedical Informatics at UCSD. He's a director of the IBD Center at UCSD and directs the clinical trials unit as well. He completed his fellowship, gastroenterology advanced fellowship at the Mayo Clinic, and also completed a clinical informatics fellowship at UCSD. Very well published. I think we all know him very well in the IBD circles. He served as the chair of the AGA Clinical Guidelines Committee and has served as the IBD-related clinical guidelines developed by the AGA. He's also the senior associate editor of clinical gastroenterology and hepatology, and his research has been well funded. P. Corey, NIH, Crohn's and colitis, the AGA, and the IOA IBD. So real pleasure to hear him give us a little bit more about the future of inflammatory bowel disease. Thank you, Sid.
Thank you again for that kind introduction, and thank you again for the opportunity to speak here. I will confess I'm not a futures person. I'm a very much in the present person. So this was a little hard for me to predict, and I probably should have borrowed from you and said this is what I predict is going to happen. So I'm going to speak that out as I go through this. Do not blame me if I sound a Debbie Downer here. So I'll start off with talking about novel therapeutics, which is the scientific advances, and then I'll talk about novel treatment approaches, which will be some of the clinical advances. So I'm starting off with 3 take-home points. We keep hearing we're moving from a TNF era to a non-TNF era, but I'll argue whether we should be doing that across the board or not. We know the future is jagged up, if only the jags can tone it down. And the age-old right drug, right patient, right time, is there a road to utopia? And we'll try to address that with novel therapeutics. And what I'll do is I'll come back and move back and forth. Some of the slides are fairly common. So in the interest of time and recognizing that this is the end of the day, let's talk about the evolving therapeutic pipeline in IBD. And the field has just exploded over the last 5 years, I would say. There was a period of time when I was graduating from fellowship where it was primarily anti-TNF therapy, and that was it. Vito was starting to come around at that time. But then over the last 5 years, multiple different mechanisms of action, which are largely non-TNF based. One of them is the S1P modulator. Of those, ozanimod has been approved. Etrasimod just published its pivotal phase 3 studies. And this class of medication, again, like I said, works by blocking lymphocyte trafficking, sequestering them within lymph nodes for IBD. So when we talked about dual targeted therapies, this is blocking the aspect of not feeding the fire. The other pathway is the IL-23 pathway, of which risankizumab has been approved for Crohn's disease. The other therapies are in advanced phases of development and likely will be approved for ulcerative colitis and Crohn's disease. Again, like I showed, this is a JAK-dependent cellular signaling pathway, which seems to add potentially some over the traditional IL-12-23 pathway, which was ustekinumab. And then, of course, probably the most game-changing medication in my mind have been the JAK inhibitors, initially with tofacitinib approval back about 5 years ago, and then more recently in the last year, filgotinib was approved in Europe, and subsequently Rinvoq or upadacitinib was approved for ulcerative colitis within the last year and expected to be approved for Crohn's disease shortly. This pathway blocks JAK-STAT pathway, and there are other medications within this pathway that are under advanced phases of development. And finally, the anti-integrin therapy. We're all familiar with vedolizumab as an anti-integrin agent. Etrolizumab, which was initially thought to be a vedolizumab plus because it was targeting another pathway of inflammation, went in very boldly with their clinical trial strategy, which I highly commend them for, but unfortunately came down short, and so that medication is not being pursued for treatment of IBD. Again, I would still request if there are updates to the slides, please let me know, because I'm just going off of... They're going to bring it. Perfect. Thank you. So just going over these medications step by step with each of the novel therapeutics. This is data for risankizumab. I'll talk about Crohn's disease first. I'll talk about positioning a little bit here, and then I'll transition over to ulcerative colitis. So these were the pivotal phase 3 studies for risankizumab for moderate to severe Crohn's disease, again designed as two phase 3 induction studies and one maintenance study, and again clearly demonstrating, as Kian had shown earlier, seems to have significant positive and favorable benefit in improving clinical remission and endoscopic remission. Key things to highlight here: it worked pretty well for patients who were refractory to anti-TNF therapy. Very exciting for our patients who fail anti-TNF agents. Perfect. So just going over the same part, the other 3 take-home points that we're going to be talking about clinical advances, I'll come to those later, but there was some focus on AI doing it all, as well as the aspect of population health management as the burden of disease is increasing. And finally, the holy grail of preventing IBD, the panacea for treating everything, which we'll talk briefly about. So going over some of the new therapeutics and slides related to that part. So I shared this data for risankizumab, and if we start putting all of these medications next to each other, we start to get a sense as to how these medications may perform relative to each other. I think one of the most important differentiating factors is we know that probably the single most important factor that influences likelihood of response is their initial response to anti-TNF therapy. So the single most important prognostic factor is prior exposure to anti-TNF therapy and how patients responded to that. So in looking at patients who were biologic naive and looking at the rates of induction of remission across the board, we see some things that are starting to stand out. Infliximab and adalimumab seem to have a higher delta as compared to certolizumab pegol, which is another anti-TNF agent, generally higher than vedolizumab, which levels off around 15 to 20%. And then we start to see better response rate with ustekinumab and risankizumab with these agents. However, with all of these medications being available, how do we think about positioning these agents? And again, the most important trials here are the head-to-head trials. That said, we've been in the field long enough to recognize that over the last 20 years, there have been 2 head-to-head trials, one for ulcerative colitis, one for Crohn's disease. And this is data for the trial comparing adalimumab versus ustekinumab for induction and maintenance of remission for moderate to severe Crohn's disease. The CView trial basically demonstrated that both of these agents seem comparable to each other in a set of naive patient population with a relatively short disease duration. One thing that I would point out is that this trial primarily looked at monotherapy with adalimumab and ustekinumab, and we all know based on SONIC, based on pharmacokinetics of anti-TNF therapy, and the fact that it's a more immunogenic target, monotherapy is probably not the best way of using anti-TNF agents. So this basically demonstrated that monotherapy with either of those agents is fairly similar to the other. I would preface that when Janssen designed the trial, they designed it as a superiority trial because they expected ustekinumab would be more effective than adalimumab. So in all fairness, this was a negative study not in favor of ustekinumab. So this is the step of one of the things where I'll bring in how do we inform positioning of these agents in the future. While we keep waiting eagerly for the head-to-head trials, an approach of meta-analysis called network meta-analysis can be pretty informative. Traditional or pairwise meta-analysis typically are comparing medications that have been looked at head-to-head, but do not inform the entire body of evidence. Network meta-analysis, on the other hand, try to inform the entire body of evidence by bringing in aspects related to wherever there's head-to-head data and combining it with indirect data. And what do I mean by indirect data? I'm referring to medications that may have been compared against a common comparator, which in the field of IBD historically has been placebo. So in this example, drug 1 has been compared to drug 2, drug 3 has been compared to drug 2, but there's no direct comparison between drug 1 and drug 3. However, this technique of network meta-analysis allows you to infer a probabilistic relationship between drug 1 and drug 3. This has been used and widely adopted across multiple fields with several high-impact publications, but importantly, informing clinical guidelines. This was very apparent during the COVID pandemic, where a series of living guidelines with network meta-analysis informed approach to treatment of a rapidly evolving disease. So this has been conducted and frequently updated when it comes to the field of inflammatory bowel diseases. This is one more recent network meta-analysis looking at Crohn's disease therapies that we conducted, and two things that stand out. The red bars represent the response for induction of remission for patients who are naive to biologics, and the agent that clearly stands out is infliximab, generally in combination with azathioprine or adalimumab in this situation. The blue bars represent the likelihood of response in those who have prior anti-TNF exposure, and here the agents that stand out are ustekinumab and risankizumab. If we start getting into more details of the data, there was some suggestion that risankizumab may be a little better than ustekinumab, at least based on indirect comparisons, but I haven't shown that level of detail here. What about endoscopic outcomes? If you recall, most prior trials for Crohn's disease, the primary outcome has been clinical remission based on CDAI, but more recently, the FDA have evolved to include endoscopic outcomes as a co-primary outcome. We know and recognize that achieving mucosal healing or endoscopic remission portends a much more favorable prognosis rather than relying only on achieving clinical remission. So this was a recent study that we updated looking at endoscopic outcomes with different therapies. And the reason I wanted to show this is because there's more recent data coming for JAK1 inhibitors in this field for Crohn's disease also. And the agent seems to stand out for inducing endoscopic remission even in patients with Crohn's disease. This next slide, next set of data is basically ranking all of these different agents when it comes to achieving endoscopic remission endpoints. And what we clearly see is 3 classes of medications tend to do pretty well. One class of medication may not do as well. And so the classes of medications that tend to do well for Crohn's disease are the ones that are blocking intracellular signaling, JAK1 inhibitors, anti-TNF therapy, and the IL-23 antagonists. The lymphocyte trafficking agents such as vedolizumab perhaps do not do as well for this indication. The open label trial that was done for ozanimod was also not very positive, and so that may not quite be an effective approach for treating our patients with Crohn's disease. How did we use data from network meta-analysis to inform positioning of therapies? I'm sharing a snapshot of the AGA guidelines, specifically focusing on active comparator recommendations. And what we identified and noted in the AGA guidelines based on this evidence coming from network meta-analysis is that the AGA strongly recommends the use of infliximab, adalimumab, or ustekinumab over certolizumab pegol. So all TNF agents are not created equal in this field. And there's weak evidence suggesting the use of vedolizumab over certolizumab in a set of patients who are naive to biologics. If we move on to patients who had prior exposure to anti-TNF therapy, those with primary non-response, the AGA strongly recommends the use of ustekinumab and by extension potentially to risankizumab if we were to update this analysis now, whereas it weakly recommends the use of vedolizumab as an alternative that exists. In a subset of patients who had prior exposure to anti-TNF agents but subsequently either lost response because of immunogenicity or intolerance, in that situation, network meta-analysis would strongly suggest the use of either adalimumab or ustekinumab for that subgroup of patients. How was this forward looking? We compared and looked at other guidelines around the time, and this is just a snapshot of where the different guidelines stand when it comes to positioning therapies. And I can proudly say that the AGA is the only one that talks about positioning agents. The ACG guidelines did not mention anything about positioning different biologics, and the same thing with the European guidelines, not talking too much about positioning agents. As you can imagine, the classes of medications have progressively increased, so the idea of positioning becomes very relevant rather than waiting another 10 years for the next head-to-head trial to come by. I would also like to add that with updating these network meta-analyses with addition of head-to-head evidence, we are getting a more precise estimate, but the results have largely remained the same. And this is seen across other fields also, wherein you can come to a recommendation maybe 10 to 15 years ahead of a direct head-to-head comparison on some of these issues by relying on aspects such as network meta-analyses. Moving on to ulcerative colitis, again, this field has definitely exploded, initially with the approval of ozanimod for moderate to severe ulcerative colitis. As we all know, it's an oral agent, an S1P modulator, which has some nuances as to how it needs to be used. These patients typically will need an EKG prior to starting these medications because there's some suggestion of slowing down of heart rate, and patients with a prolonged QTC will require to be monitored. These patients will also need gradual escalation of therapy. And as with small molecules, the aspects related to drug-drug interactions become very relevant here for some of our patients. Granted that our IBD patients may not have all of these comorbidities, which are generally associated with advanced age. Another S1P modulator, which is under FDA review, is etrasimod. This is data from the pivotal etrasimod trials, again demonstrating high efficacy in achieving endoscopic remission as well as clinical remission in patients with ulcerative colitis. Again, for both of these agents, tend to perform better in patients who are TNF naive rather than patients who had prior exposure to anti-TNF therapy. This does not imply that it doesn't work for the latter group of patients. Neither does it imply that these agents should be used ahead of anti-TNF agents. So it's not that the exposure to anti-TNF therapy automatically renders these medication ineffective. It's the fact that this medication does not work well for somebody who is treatment refractory otherwise. This is probably, again, I'll reiterate this, I do think this has been a game-changing medication when it comes to patients with moderate to severe ulcerative colitis. I have not been paid by AbbVie to do this, but I sincerely feel that this is a medication that has been pretty helpful for our field. This is a JAK1 inhibitor used orally, which is raising the bar for rates of achieving remission. We are seeing deltas over placebo of close to around 25 to 30%, something that we had only seen with infliximab in the prior ages. But since then, most other medications were achieving deltas over placebo of 10 to 15%. Which is what this is data showing the same thing is, first of all, between the pandemic and now, this figure has doubled. So I used to stop at tofacitinib in 2019, and all of a sudden I've added 5 different medications. So that is to credit to the field and the scientists in the field and all the pharmaceutical companies for taking the chances with all of these excellent medications, which have expanded the treatment options. But few things that I want to highlight is the delta that we see over placebo with a medication like upadacitinib, which parallels what we had seen previously with infliximab. How do we apply this information through a network meta-analysis? This was work that was done by Laurent Perrin-Pirellet, and this is a complex table that I don't expect you to read, but on the top corner is upadacitinib, and everything that is blue suggests that that agent is more effective than other agents. So across the board, upadacitinib was more effective than any other agent that is used for treatment of moderate to severe ulcerative colitis, both for outcomes of achieving clinical remission as well as endoscopic improvement in the field. There were some other agents that we can talk about which tend to stand out, which tend to demonstrate superiority over others. But I think the single take-home point is JAK1 inhibitors, in particular upadacitinib. I cannot say the same thing about filgotinib because that medication may not have been adequately dosed in their clinical trials for some reason that we can talk about later. But I said the future is all jacked up, but as long as the JAKs can tone it down, and this is the reason why I brought it up, is the safety profile of the medication. This was the pivotal oral surveillance study in older patients with rheumatoid arthritis with one cardiovascular risk factor, comparing 2 doses of tofacitinib with a TNF-alpha antagonist. This was the approved dose of tofacitinib in rheumatoid arthritis was 5 milligrams BID. They decided to study 10 milligrams BID in addition. If you recall, for ulcerative colitis, for patients who are TNF refractory, the dose is 10 BID, but in rheumatoid arthritis, that is not the usual dose. But what this trial basically demonstrated is, across the board, tofacitinib was generally associated with higher risk of adverse events, and that ranged from higher rates of major adverse cardiovascular events, malignancy, serious infections, opportunistic infections, pulmonary embolism, venous thromboembolism, and death. And most of that was seen with higher doses of tofacitinib as compared to usual doses. So the FDA took a step back and said, we're limiting all approved uses of JAK inhibitors. They made it a class label across indications based on this pivotal trial, suggesting that all JAK inhibitors across all indications should only be used in a subset of patients who have not responded or cannot tolerate one or more anti-TNF agents. So by design, these became a second-line therapy. Europe has been more pragmatic in its approach, suggesting that the use of this restraint largely applies to patients who are older and have a cardiovascular risk factor, rather than taking it away from all patients. So, summarizing this part about novel therapeutics, I think that TNF-alpha antagonists may be the most effective first-line agents for patients with Crohn's disease. Risankizumab and ustekinumab, and in the future, very near future, upadacitinib are the most effective second-line agents, especially in those who have primary non-response to anti-TNF therapy. In patients with ulcerative colitis, infliximab and vedolizumab may be the most effective first-line agent. Ozanimod is an attractive oral alternative, but the safety of the agent needs to be understood a little better in real-world use. Upadacitinib may be the most effective second-line agent after failure of infliximab. Tofacitinib and ustekinumab may be potential alternatives. Let's move to the next part. An argument that we often hear is, what about the safety of these agents? Safety should be the number one thing when we're thinking about a wide variety of these agents that are available. And you've probably all seen the various iterations of this pyramid arguing that a gut-selective medication is intrinsically safer than any agent that is broadly targeting other pathways of inflammation. And factually, that is probably true. The intrinsic immune suppression potential of these different medication varies, and gut-specific medications may be associated with a lower risk of long-term infections. However, recognize that half of the serious infections that happen in our patients with IBD generally happen within the first 6 months. So the second factor that plays a critical role in informing the safety of any treatment agent is its ability to control the disease effectively. There's no point of using a safe medication if you're going to be using prednisone along with it to keep the disease under control if your patient continues to be frail and doesn't improve. So I would argue that from a patient's perspective, it's not the safety of the medication that is more important. It's the safety of the treatment strategy that matters. So I do not buy the argument that a safety-first approach should be the approach that is used. We demonstrated this through a series of studies, concluding in this meta-analysis with 20 head-to-head studies comparing the risk of serious infections with different agents. And what we observed is that while a gut-specific medication like vedolizumab, which is equally effective to anti-TNF therapy for ulcerative colitis, in that group of patients, it is actually associated with a 50% lower risk of serious infections. But in patients with Crohn's disease, where the drug may not be as effective, there is no difference or safety advantage that vedolizumab may have. Similarly, comparing ustekinumab to all of these other agents in patients with Crohn's disease, where it is a pretty effective medication, we did observe that ustekinumab is associated with a lower risk of serious infections as compared to anti-TNF therapy, and similarly as compared to vedolizumab. So the safety profile of advanced therapies may vary and is influenced both by the intrinsic immune suppression potential as well as the treatment effectiveness in controlling the underlying disease. So in talking to fellows, I always emphasize, should we choose effectiveness of an agent over the safety of an agent across age groups? And I always say we should almost always choose an effective agent over a safer medication. So my conclusion from this part of the talk is, while there'll be a lot of people that'll talk about oral therapies being the future, and that is probably a patient preference too, at this stage, and potentially for the foreseeable future, unless the JAK inhibitors can demonstrate a good safety profile, I still think for most patients with Crohn's disease, anti-TNF therapy is probably the most effective first-line agent. I do not buy the argument that we can start off with a safer agent early on, and if it doesn't work, we can go to a next agent. We know that time is money for Crohn's disease. Early effective intervention with your best agent is your best approach to changing the natural history of disease. So for most patients with Crohn's disease, in my opinion, anti-TNF therapy is still the best approach and should remain. In patients with ulcerative colitis, we have other alternatives like vedolizumab, which is an excellent agent for treating those patients. Moving on to the more futuristic side of thing about right drug, right patient, and the road to utopia. In this part of the talk, I'll mention some aspects related to combination therapy, predictive biomarkers, and the idea of prognostic biomarkers. I think one of the most pivotal review articles that I read for our field was this NAJM review in 2021, which was trying to reframe our thinking about immune-mediated diseases. Instead of talking about an organ-based approach, think about signature cytokine hubs. And different diseases have different cytokine hubs through which they act and mediate their effects. As you can see in the signature cytokine-based concept at the very bottom, across multiple different immune-mediated diseases, the single most important mediator is anti-TNF therapy, which is why it seems to be effective across IBD, rheumatoid arthritis, psoriasis, as well as ankylosing spondyloarthropathy. In contrast, for different diseases, there may be other signature hubs. IL-23 pathway, for example, seems to be a very IBD-focused hub, which is why these medications tend to work well. Whereas if you start moving to ankylosing spondylitis, IL-17 tends to be a prominent signature pathway in this group of patients. So I think taking a step back, maybe a cancer-like approach, that it's not an organ-based treatment that we are looking at, but rather what is the signature cytokine that has been expressed by the specific disease. Over the course of time, I think that is probably going to be the way to rethink about these diseases and have innovations in clinical trial design to facilitate something like this. This idea of a signature cytokine hub is where the idea of rational combination therapy also comes in. Think about how different medications work and then combine them. And we showed earlier the proof of concept here with the Vega trial, which was a phase 2 early study. I fully agree and acknowledge that the combination therapy is not ready for prime time, but give it 5 more years, we'll have better trials, better understanding of the safety profile of these therapies. And again, pharmaceutical companies, biosimilars, will be in a position where they can probably bundle these medications of different classes together and sell them as a unit, rather than us relying on insurance companies to focus on getting an AbbVie drug with a Janssen drug approved. Talking about the whole idea of predictive and prognostic biomarkers, this was a very interesting review and a very useful review in gastroenterology. Just thinking about what do we mean by a predictive biomarker versus a prognostic biomarker. A predictive biomarker is telling us what is the likelihood of response to a particular medication. A prognostic biomarker is telling us, is this patient at high risk for complications in general or not? So I'll talk about data for predictive biomarkers and prognostic biomarkers next. And we've been talking about this for ages, about the idea of predictive biomarkers for biologic therapy. The only things that we know for that seems to work is there are clearly some pharmacological factors that influence the likelihood of response to medications, and that generally implies trough concentration, tissue drug concentration, and the presence of anti-drug antibodies. And we know that there's a clinical phenotype of patients that is more or less likely to respond to medications. There's all this promise of genetic markers, microbiome signatures, immune cell infiltrate patterns, and drug target expression that in the future will hopefully inform us. I just wish that field was moving faster than it has. Talking about microbiome signatures, this was a very exciting study from Ashwin Ananthakrishnan looking at microbiome signatures that predict response to vedolizumab. Looked at stool metagenomes of IBD patients starting anti-integrin therapy, assessed prospectively, and what they observed is that vedolizumab responsive patients tend to have higher abundance of butyrate-producing organisms, and there was a baseline enrichment of 13 microbial pathways. And what they inferred is the combination of a clinical and a microbial signature is much better at predicting likelihood of response to vedolizumab. What happened after that? People started doing it with each and every medication. So this is data for ustekinumab. Again, similar findings. Patients who are responding tend to have enrichment of their microbiome with this agent. You'll see some names prop up in one, other names prop up in other. I am a outcomes researcher For me, those names don't make a lot of sense. So what do we do at the end of this? Let's try to synthesize all this data. And this was a very interesting systematic review, which looked at, can a microbiome signature predict whether somebody is going to respond to drug A versus drug B versus drug C? And the conclusion from this systematic review, looking at the entire body of evidence, was that changes in the microbiomes of fecal and colon samples after treatment did not differ significantly among biologic agents. All patients who were responding produced decreases in relative abundances of different bacteria. So people who respond tend to regain their diverse flora again. It's not necessarily a microbial signature that'll help you identify whether somebody will respond to a particular medication or not. This was another exciting study, now almost 10 years old, that I was very excited about, just graduating from fellowship at that time. It was this idea of in vivo imaging. So this was Marco Tenurath and Raja Atreya's group in Germany, who've done a lot of pivotal studies. And what they looked at is using confocal laser endomicroscopy. They looked at the number of membrane-bound TNF-producing cells. And what they observed across the board in response to an anti-TNF agents, a subset of patients who were expressing high levels of membrane-bound TNF had 92% response rates, whereas a subset of patients who had a very low expression of membrane-bound TNF on CLE that was observed had only a 15% response rate. For me, this was game-changing, but that was 10 years ago, and there's not been a follow-up study. And I think this is the idea of reproducibility of some of these very exciting findings that I find disappointing. Similar story with oncostatin M. This was a series of very elegant studies, first demonstrating that inflamed intestinal mucosa expresses high amounts of oncostatin M and its receptor, and this correlates with disease activity. They subsequently went into looking at patient populations. So in the initial part was preclinical, then a translational study, and then a human study looking at clinical trials. And what they observed is that patients refractory to steroids and immunosuppressive therapy form two clusters, either they're high or low oncostatin M module expression. And what they observed is that patients who have a high colonic pretreatment oncostatin M tend to be anti-TNF refractory. Unfortunately, similar data at that time was not available to tell us whether those patients respond better to vedolizumab or to ustekinumab or to a JAK inhibitor. In fact, quite the opposite. Subsequent studies have shown that patients who have high pretreatment oncostatin M are also less likely to respond to vedolizumab. So are these predictive biomarkers or more prognostic biomarkers? And what I would argue is that these are probably more prognostic biomarkers that are helping us identify patients likely to have poor outcomes. The one field where this has been different is this idea of pharmacogenomics to identify patients at high risk versus low risk of immunogenicity to anti-TNF therapy. So pivotal PAN study, and subsequently there were other studies in various immune-mediated diseases that looked at the expression, the genotype, and patients who were expressing variants to HLA-DQ A105, or the risk immune test that Prometheus offers. Roughly 40% of the population may have variants to HLA-DQ1, 60% will be wild type. Those who have variants have a significantly higher risk of developing immunogenicity to anti-TNF therapy, and those variants have a higher rates of achieving of loss of clinical response. In contrast, the 60% of the population which does not have immunogenicity, does not express this variant, 20% of those patients will produce anti-drug antibodies, and their rates of loss of clinical response is also low. So this is something that you can actually apply in clinical practice, potentially to understand whether to use combination therapy in a patient who is risk averse, in a patient who is concerned about going on in a combination of an immunomodulator and anti-TNF therapy. This test can be informative. Another promising data from a phase 2 study looking at predictive biomarkers is this data from Prometheus Biosciences looking at their first-in-class monoclonal antibody, which is the TL1A monoclonal antibody targeting TL1A receptor. They argue that it's both anti-inflammatory and may have anti-fibrotic effects. I would ignore the anti-fibrotic effects because I do not have any data to support any of that. But their pivotal phase 2 studies here looked at patients with ulcerative colitis. And while the figure on the far side of the screen from here suggests that this is upadacitinib level rates of achieving clinical remission. So we're seeing deltas of 25%, but recognize this is a phase 2 study, and phase 2 studies are generally overly optimistic because the patients may not be as drug refractory. So be cautious in interpreting that part, but come to this side of this. They have a companion diagnostic which is looking at patients who express TL1A versus those who do not express TL1A. And what they observed is the placebo-adjusted differences for all comers was 25%, but all of a sudden, in a subset of patients who had companion diagnostic positive, the delta over placebo was close to 40%. So this is truly potentially a predictive biomarker suggesting that those patients who express this will have a significantly higher response to this specific medication, whereas the delta goes down for a subset of patients who may not express this. Again, I'm cautious in interpreting this because these are small numbers from a phase 2 study, but at least there's a field or a move towards something like this. Moving to a very exciting prognostic biomarker, which in all fairness is where I think the field is probably better served because of our inability to do the predictive biomarker stuff despite many years of effort. This was a very exciting preclinical, translational, clinical study evolving into a clinical trial. So with the next 3 slides, I'll show you data for this blood-based prognostic biomarker that was developed by Miles Park and his group. They looked at biologic and immunosuppressive naive patients with IBD, used machine learning methods to whole blood transcriptomic markers, and validated a 17-gene qPCR classifier. And they said, based on these 17, this specific expression on qPCR, there'll be patients who have high expression of this, and there'll be a subset of patients who have low expression. And the series of bars at the bottom is basically showing that the prognosis of patients who have high versus low expression of this biomarker or a prognostic biomarker, the outcomes are very different. And this seems to perform better than our conventional measures, such as endoscopic disease activity, as well as clinical risk scores in this situation. They show it in parallel both for ulcerative colitis and Crohn's disease, arguing that this qPCR classifier performs better than endoscopic scores and clinical scores. Then moved it on further into clinical and patient cohorts independently, trying to look at outcomes for these patients and the likelihood of needing escalation to stronger therapies or failure of initial therapies. And here what they observed is that those who have high expression of this tend to move to stronger medications, tend to fail their original therapies, failure of corticosteroids, steroid dependence, anti-TNF therapy, second-line biologic therapy, whereas those who have a low expression of these tend to do much better, tend to be more treatment responsive in general. And from there on, they've developed a profiled clinical trial of around 400 odd patients, both in patients with ulcerative colitis and Crohn's disease, where they're comparing a treatment strategy based off of this qPCR classifier, looking at patients with high expression, use an aggressive approach for those, whereas those with low expression, you can do a sort of a step-up approach versus the conventional approach of a top-down for all patients. And so I'm eagerly awaiting the results of this study, which I think is definitely an innovation in our field in trying to think about how these biomarkers can be effective in ascertaining how we treat diseases. So summarizing this part of the talk, what do we think determines response to therapy? A lot of factors, a lot of omics probably determine response to therapy at some point. At this point, the only thing that we know is that there are favorable clinical and pharmacokinetic factors, and there are unfavorable clinical and pharmacokinetic factors. These are more prognostic biomarkers rather than being predictive of response to a specific therapy. In the future, we will evolve further from this. We're using a systems biology approach in being able to identify the right patient, right drug at the right time. Okay? So I talked about the scientific advances. Let's talk about how do we see the field moving forward when it comes to clinical advances. And this is how do we break the therapeutic ceiling. The farther side, or the yellow side, is basically talking about scientific advances. And I talked to you about new therapeutics combinations, as well as this idea of molecular classification of disease. In the second half of the talk, I'll talk about two specific aspects of non-invasive monitoring to advance the field forward, as well as strategies to improve healthcare delivery. I'm in Palo Alto, Redwood City. Cannot go without talking about AI in the field of IBD also. Is it going to change our practice? Multiple different potential applications here. Perhaps the most exciting of this is this idea of automated IBD imaging exposures, which applies to enterography, endoscopy, and histology, as well as other ways to improve our lives, as well as inform data through natural language processing and potentially predictive modeling. So, three most commonly types of machine learning methods that are used in IBD. The first one is support vector machines. That's the example on the right side. It's basically trying to draw a line and trying to classify patients differently, just looking at patterns of expression. And in this situation, trying to correlate fecal calprotectin profiles versus the risk of surgery. The other aspect on the side is the aspect of random forest, which is an ensemble approach with multiple decision trees. So just looking at data patterns and branch points at each level, the machine learning method is trying to identify patients at high risk of surgery versus low risk of surgery by following each branching logic. Perhaps the most exciting part here, and where I think definitely the field of colon cancer screening has gone, and the field of IBD will also go, is this idea of artificial neural networks in terms of image analysis that applies to endoscopy, radiology, and histology. This is going to level the playing field to a certain extent, wherein it's not just limited to high centers or experts trying to read an endoscopy or experts trying to read an MRE. But if we can do this broadly applicable, we'll probably make the biggest difference in quality of care and improving population health. Ideas of natural language processing, again, just for those of you, brief introduction here is, can you read through our notes and tell me some aspects that I cannot pick out, some patterns that I cannot pick up by myself? And this is basically going through a note and looking at patterns and potentially applying that subsequently to research, converting unstructured clinical notes into structured data, which can subsequently be used for predictive modeling, is the promise here. What about population health? Why do I care about population health? This is the reason there are not enough IBD doctors, especially with a number of medications that are coming about. The disease is exploding. This was a very pivotal review from Gil Kaplan talking about the 4 epidemiological stages of global evolution of IBD, talking about a phase of escalation, accelerated incidence, compounding prevalence, and the analogy of a tap at the bottom, what the exodus is happening. We know more patients are being diagnosed with IBD. We know that people are living longer. So there is compounding of prevalence that is happening. So even though in the Western world, the number of new cases that we are identifying seems to be plateauing, but as everybody is getting older, there is compounding prevalence so that the number of IBD patients that we are starting to see is much higher. At the same time, countries like newly industrialized countries in Asia, South America are in this phase of accelerated incidence where the number of patients is increasing there, and they will subsequently transition into a stage of compounding prevalence. So the thought is, in the next 5 years, roughly 1% of the patient population is going to have IBD. Roughly 30% or a third of the patients that we see in our clinics are going to be older than 60 years of age. How do we manage those patients? How can we reasonably take good care of these patients? And this is where the idea of population health management comes in, where the field is moving and needs to move faster. Population health management implies the coordination of care at a macro level to improve outcomes and effectively manage the clinical and financial risk for a defined group of patients. the CMS says population health management involves both a clinical perspective focusing on delivery of care to groups enrolled in a health system, as well as a broader perspective focusing on the health of all patients within a geographic area, emphasizes multi-sector approaches, innovation of non-clinical interventions to facilitate some of these things. 3 aims of population health management are to improve the quality of care, improve outcomes at a population health level, and reduce healthcare costs. So all those arguments about novel therapies, combination of biologics, early aggressive therapy with combination of biologics for all that falls flat because the cost of this is tremendous and not sustainable, especially if we start to say 1% of the population will have IBD. So this was sort of a framework for population health management that we had thought about a few years ago and that we are gradually working towards. There are 3 steps in population health management that are critical. First is appropriate and adequate risk stratification. Identify your high-risk population and identify what are the sources of variability as we manage these patients. The low-risk patient population can potentially have infrequent visits and more infrequent check-ins that happen without requiring as much resources, but the high-risk patient population requires more intensive and closer follow-ups. The next part is this whole idea of chronic care models. How do we manage these group of patients more effectively with innovations in healthcare delivery that go along with this? And finally, how do we track these things and how do we measure these aspects? I'll give you just one example of an aspect of remote monitoring that I was involved with Larry Kozinski, which was Project Sonar. This was a community practice-based IBD intensive medical home and looked at an alternative payment model by collaborating with Blue Cross and Blue Shield of Illinois. And it had 4 main components. It embedded a technology-enhanced patient engagement platform, embedded clinical decision support tools within EHRs to minimize variability of care, used a risk assessment tool that determines the course of action to be taken, and it uses the claims data to analyze the impact of the program. So it's addressing all aspects of population health management. And what it essentially is that patients at an intake will achieve whole person care. So we'll understand what is their risk from a disease perspective, what are their aspects like mental health and other things that can impact their healthcare resource utilization. Sign them up for a program with monthly pings to ascertain how their disease is doing. This was monitored by a nurse of all of those patients who were responding. Patients who had a significant uptake of symptoms were proactively called into the clinic before they flare up and end up in the hospital. And what they were able to demonstrate is that a strategy like this was overall cost saving. How do we synthesize this entire body of data on digital health technologies with other approaches for remote monitoring, web-based portals, mobile applications, telemonitoring, and telemedicine? Overall, it seems that these strategies tend to decrease unplanned healthcare utilization, such as hospitalization, and tend to decrease healthcare costs without a significant impact on IBD disease activity, IBD quality of life, and the risk of symptomatic relapse. So it may not be as promising as it might sound across the board, but it definitely has aspects of decreasing unplanned healthcare utilization in an efficient way. What about the Holy Grail? Can we prevent this? We are worried about the high burden of IBD, but how can we prevent this? And again, this comes back to the talk on diet and microbiome that my namesake gave earlier, which was the impact of diet, the impact of food additives, and all of those things. Multiple different facets here that play a part. Diet being a key component, physical activity, smoking, stress, and a multitude of other things that contribute to the development of IBD. And I'll leave you with this one final study, which was a provocative study, an epidemiological exercise trying to understand the impact of lifestyle factors on prevention of IBD. So this was not a clinical trial. This was a bunch of prospective cohort studies. And what they did is they classified based on epidemiological exposures that influence the risk of IBD. They said, well, if each of these factors, such as good physical activity, a healthy diet, low stress, low cigarette smoking, low exposure to NSAIDs, if each of those individually tend to decrease the risk of IBD, how about we create a healthy lifestyle score and see if it may have modified the risk of developing IBD. And what they observed and they inferred is that in 3 prospective US cohorts, adherence to low-risk factors could have prevented roughly 40% of patients, roughly 40% of cases of Crohn's disease and ulcerative colitis. They did confirm this in 3 additional European cohorts. So definitely provocative, but a little bit of an a stretch to try to think that these interventions directly would prevent it. This is not going to happen today. This is something that is a policy level changes when it comes to food additives and a lot of other things that need to happen in the country for this to happen. So what are my take-home points here? I think TNF-alpha antagonists are still the best option for Crohn's disease and severe ulcerative colitis. I think JAK1 inhibitors are potentially game-changing oral therapies for ulcerative colitis and Crohn's disease. I think the road to utopia is long. Till then, mass personalization of therapy based on comparative efficacy and safety of therapy is better than playing the lottery. AI has tremendous potential, in my mind, primarily on imaging focus and ANN networks. It may not be as accurate or useful for clinical prediction. As the burden of IBD increases worldwide, population health management strategies will be important to manage healthcare burden. And finally, prevention is aspirational, but should not deter us from taking that approach. With that, I'll stop, and I'll be happy to answer questions.
If these are still working. Are these hot? This one was that to begin with? Okay, perfect. Sid, thank you so much. That was a beautiful talk. That was a really great talk. I'll start off with a question, and then maybe we can open up for a couple of more before we wrap up. So I think you laid out very nicely the current state of clinical trials and sort of the best evidence, the best levels of evidence. I mean, the other thing on the provider side, of course, is enrolling these patients in clinical trials and thinking about the patients who, how likely are they to go into placebo arm. And so you already were rightfully pretty pessimistic that there's going to be a lot of head-to-head studies probably in the future. But what do you envision as the future of clinical trials? You already mentioned that some of it is sort of the diagnostics to help personalize. But what do you envision as far as for our patients? How would these change? Non-powered reference arms or things like this. What are those beneficial? Or are those things that you see changing in the?
No, that's an excellent question. I think the impetus for this needs to come from the FDA, because historically all trials are placebo-controlled because there was no standard of care. Now there is a standard of care, and I think that standard of care should be anti-TNF agents at this point. So unless the FDA makes that impact, it's hard to see too many changes. I think it is a risky initiative, especially with what happened with etrolizumab, which was a huge program, very aspirational, multiple head-to-head studies, and the drug failed in its primary intention of getting approved. So I think that was a downer. That said, there are other innovations in trial design, such as platform trials, wherein you have a common protocol, a similar protocol, so a patient can get in and get out of trials, coming in with different medication options within that. So you have a common, smaller group of placebo patients instead of each trial having its own placebo. Have a platform with 5 different medications with 1 placebo through which you're able to statistically then infer which medication is the winner, which is not. So again, it does require a lot of thought in developing something like this, and a lot of courage from pharmaceutical companies.
Well, who else has questions?
What are your thoughts on treatment for mild Crohn's, especially for first biologic?
Yeah, I wish I could define mild Crohn's. I think that is my biggest struggle, is I don't know what mild Crohn's is. For me, mild Crohn's is incidentally identified ileitis. Somebody who's asymptomatic has a short segment of ileitis when you do a colon cancer screening. You do extensive testing with either a capsule or an MRE, see a very limited short segment disease. I don't think that patient needs treatment. However, if you have somebody who has mild symptoms but more extensive disease, when we look at things for a patient like that, you can definitely start to think about biologics for that group of patients. Again, I will emphasize, I strongly think early intervention is key for somebody at high risk of disease complications. So I think for a patient like that, for me, it's still an anti-TNF agent or maybe an IL-23 antagonist. However, that is a group of patients where trials of dietary therapy, FMT, and other things potentially have a role.
You know, in rheumatologists, they use combination therapies without any reservations. And so if we have an experience already from there, although it may not be exactly extrapolated to IBD, but there's a big incentive there.
Yeah, no, exactly. I fully agree. Full disclosure, my wife is a rheumatologist, and this is dinner table conversations that we have. I tell them you don't know how to use your medications well because there's no therapeutic drug monitoring, and they willy-nilly change medications and do things. So I fully agree. I think there's things that we can borrow from their field, especially when it comes to safety of certain medications, because they have a much larger exposure to some of those things, as well as understanding the idea of cytokine hubs and how do you rationally combine some of these medications.
So I was curious, from a practical perspective, when you discuss with patients, you mentioned you always go for the most effective drug, but there's a huge discrepancy in the safety when you start getting to the safety part. So when you have that discussion, one, how do you address that? Second, maybe this is just my biased perspective, and I was curious, when you were doing the safety network meta-analyses, I feel like the data is kind of all over the place. I mean, putting aside anti-TNFs, but for the IL-23s, Veto, you know, how do they risk stratify? It was all over the place. So I was kind of curious, when you were doing that work, did that pan out, and does that affect how you interpret your own results?
Absolutely. Great question. I disagree with you where you said there's a huge difference in the safety profile of medications because it depends on which outcome you're looking at. Malignancy is probably the only one, and that is for lack of data on IL-23 and other agents. The absolute risk of lymphoma in a patient with anti-TNF therapy is 1 in 2,500. The risk of surgery in a steroid-exposed patient with Crohn's disease is 1 in 5. So for me, that is the discussion. It's the absolute risk that is important, and lymphomas, the absolute risk of lymphoma is still pretty low. My discussion about serious infections is basically talking about your risk of disease complications. If I can control your disease well, get you off of prednisone, get you feeling healthy, good nutritional status, that is probably the most favorable thing for a patient rather than going into the safety profile. We have data to show that age is not a good marker. It's the frailty status that probably matters more. The number of comorbidities itself is also not a good marker. So that's where my main discussions are around malignancy and serious infections. I do not go into the details of the risk of lupus, the risk of exacerbation of psoriasis. I think that number is very small regardless. With regard to your second questions, I fully acknowledge that network meta-analysis for clinical trials is not meant to ascertain the safety of agents. Trials are not designed for safety outcomes, so any network meta-analysis, and there have been a few that have been done, they say that all agents are safer than placebo. That does not help us. So for safety of an agent, you need real-world studies, registry studies where everybody's coming in, and if you look at data for open label extension, so if you look at patients who are responding to medications across all agents, the overall risk of serious infections is the same. If you look at registry studies, which is only available for anti-TNF therapy at this point, that's when the true picture of infection starts to come up. And unfortunately, we do not have that data for vedolizumab or ustekinumab or any of the other agents. So I do not think there's a huge difference in the safety profile of different medications. I frequently rely on real-world evidence to talk about safety of therapies.
Great. I think with that, we'll stop. Thank you so much, Dr. Singh. Really, really insightful. Really appreciate it. So to wrap up for tomorrow, then join us tomorrow morning, same bright and early, but it's a half day tomorrow. We're going to be having a great discussion on advances in endoscopy. We'll have some interactive esophageal cases with a panel discussion, and then we'll have a keynote at the end with Dr. Speckler, who's an excellent keynote. So hope you all join us for that. Thanks.